also need justice and support for women who are experiencing that. Safety, right? Physical safety, emotional safety, psychological safety are all hugely important. And then some work environment concerns, right? Sexism, racism, harassment, double standards, right? That feeling that you need to work twice as hard to get half the respect as a woman. And we found that about 2/3 of our respondents experienced sexist or unfair treatment based on their sex or gender, mistrust of their supervisor in support of supervisor support in times of hardship, or rumors affecting their reputation. And this was seen as a barrier to their career progression, right? 2/3 of women. As a break from all that doom and gloom, we did ask, like, what's something that has shifted recently that has improved your experience, right? Updated grooming standards were a huge hit. And some of it is just like, you feel better, but also like your hair now doesn't bring your helmet over your eyeballs. Like you can see when you're firing your weapon. You're like, great. We are starting to have gear and uniforms that fit. Again, we need to get them to the women. Expanded parental leave policies have been positively impactful, and then because our respondents were primarily Army, the holistic health and fitness system came up as hey, this is hugely beneficial and people should have it. I know I threw a lot of numbers and a lot of information at you in the last 15 minutes. There is more to follow. We did just scratch the surface of the results of this survey. We'll be compiling this and putting it into a document called the 2025 Critical Topics for the Advancement of Women's Service Members. That will be available on our website at thevalkyrieproject.org. You can sign up for our newsletter. You'll get it. If you have not yet completed this survey and you would like to, you can scan this QR code here. We're still accepting responses. And then if you have any more questions, you can come find me, chat with me. Our Valkyrie Project contact is up there. My personal email is at the bottom. And with that, I will thank you all so much for your time.
All right. We will now take a 10-minute break and be back at 2:15. Gentlemen, please take your seats. Our next panel will discuss the education, understanding, and availability of female service members' health and wellness needs, moderated by Katie Schulz.
All right, well, good afternoon, everyone. What a privilege to be here. I want to thank the Valkyrie Project leadership for inviting me to moderate this panel today. Certainly, this is my favorite topic. I'm Commander Katie Schulz. I am active duty. I'm approaching my 20th year of service in the Navy. Currently, I am running the U.S. Navy Medicine's Office of Women's Health. So covering women's health for the Navy and the Marine Corps. Professionally, I'm a certified nurse and midwife and a fellow at the American College of Nurse and Midwives. So women's health is my clinical area of expertise. I still keep up in current clinical practice several days a month. Usually I'm practicing over at Fort Belvoir at ATMC Medical Center. Have an awesome group of panelists with us today to talk about holistic health. They all have a wealth of expertise to share with us. And just kind of a joint disclaimer from all of us that any of the views that we share today may not necessarily reflect the views of the Department of Defense or any particular service. So just in talking about holistic health, as I've listened to our speakers and our panelists today, healthcare seems to be a very hot topic and one that I can tell that everybody's interested in, and I can definitely hear the impact healthcare is having, or access to or lack of access to healthcare, how it's impacting service members. So hopefully some information that we have today is helpful. And we'll look forward to hopefully have some time for questions at the end of the panel. So I'm going to let each one of the panelists introduce themselves, and we'll get started.
Hi everyone, I am Dr. Rebecca Ivory. I'm a doctor of nursing practice. I'm a psych and mental health nurse practitioner, and I specialize in something called operator syndrome. And as a subspecialty, subconcussive TBIs, the mental health outcomes, specifically how to treat them. That is my primary focus. I am clinical. I own a private practice called Tactical Psychiatry. That is how I've worked with about 300 male special operations operators. I've worked with maybe 50 enablers. Those are primarily women. I also work with women operators. I don't just work with the military. I work with federal agency. I also work with our international partners. So I do a lot of international work as well. And I am also a faculty member at Emory University. I am not necessarily representing their views also while we're here. So I do a number of things. I'm on international breaching policy boards where we set standards for explosive breaching. I'm also part of the SEAL Future Foundation Health Board. I am also part of the Best Defense Foundation, Dovetail Landing in Alabama, so I do a ton of other work. And I'm also a scientist. And again, my specialty is operator syndrome, specifically with breaching. I'm going to talk a little bit about my research as we go along. Yeah, that's it.
So good afternoon. I'm very honored to be here. My name's Carla Long. I have a PhD in clinical psychology. Back in 1990, I took the best job I ever had. I joined the Army, and I was in the Army from 1990 to 2016. In 1998, I took a path that was another great opportunity that I had. I went through the Army Survival School, Survival, Evasion, Resistance, and Escape, so that I could become their SEER psychologist. And that began my career in special ops, and was in a number of units, deployed a number of times, and retired in 2016 as the command psychologist at SOCOM down at MacDill. I'm an operational psychologist, so I spend a lot of time consulting to whether it's national security or assessment selection. I love doing assessment selection. I've even done personal recovery operations. We find a lot of psychs do that. I have an LLC now that I'm retired. I tend to do surge support to assessment selection throughout Special Operations Command or with other Army organizations. And I am also on the board of directors for a nonprofit called the Special Operations Warrior Foundation, where we provide full education funding to for the children of fallen special operators or a spouse. The spouse has died and the service members on active duty within SOF, their kids will get education funding too. I'm also a military spouse. My husband, one of these days, is going to retire. And so I'm a military spouse and we're stationed here in DC.
All right, good afternoon. My name is Melissa Hawkins. I am a doctor of physical therapy. I work in sports medicine with a special interest in the tactical athlete. I'm also a retired Sergeant Major of the Marine Corps, or in the Marine Corps, not of the Marine Corps. And I actually completed my career in the reserves so that I could, in fact, pursue my civilian job. And I had a very unique opportunity to combine both my military and my civilian careers for the benefit of the service. And I served as a senior enlisted advisor for the Human Performance Branch, which allowed me to really help the service, the institution as a whole, with human performance optimization efforts. So my specialization is really optimizing human performance in the warfighter. Now that I'm also retired, I have sort of pivoted that now to the veteran space, kind of helping veterans with their transition and helping them with their holistic health.
So great. I planned some questions that I was hoping could allow each one of our panelists to share their unique area of expertise. So Carla, a question for you is, when thinking about resilience, what are some characteristics or commonalities amongst successful female leaders?
Okay, so there's some good news, and there's some news that, based on research, we're hoping to change. So there are stereotypes, as we all know, about how people expect female leaders to be. And some of that you heard here today already. Some of the research suggests that gender stereotyping and bias against female leaders kind of highlights why we don't have as many leaders at the very top of organizations that we'd like to see. And so we know that women that kind of violate some of those stereotypes regarding nurturing and regarding assertion tend to get penalized when it comes to hiring and evaluations, more so than males that have those same characteristics. And this is a bit dated, 2011. 7,000 leaders were looked at, and of no surprise, the majority of the leaders, especially at the top, were men. And the higher up the level of leadership you went, the more men there were. Even though women tended to have very high scores when it came to things like competencies, nurturing competencies, such as developing others and building relationships and exhibiting things like integrity and engaging in self-development. And some of that, those kind of things that you've heard already. You've probably also heard, or maybe experienced within yourself, some of those quotes like, we have to work twice as hard, just as good, and things like that. And the constant pressure that no matter how high up you go, you can't rest on your laurels, you have to keep pushing and keep driving. So that puts a lot of stress on women. Okay, so we know that that's out there, but there are characteristics that we know that we see amongst successful, resilient women. How many of you have read the book Grit by Angela Duckworth? Great book, and she talks about, sometimes you have to have a baseline level of talent, but you put in that effort, and talent times effort equals skill, and then skill times effort equals achievement. We know that grittiness, you see a lot of that in women that tend to be successful and resilient. And not just gritty, but hardy. These are folks that, when put in a situation, they're like, okay, this is a tough situation, but I'm going to take on that challenge. They look for challenges. And if you talk to a lot of women that have been successful in some difficult situations, they didn't take on that situation or that job because they wanted to be the first. They took on that job because they were like, oh, what's going on over there? that looks interesting. I want to do that. And then, regardless of what that standard was, they pushed themselves to meet it. So a lot of times in successful, resilient women, we see them having a growth mindset. That they see an obstacle not as something that's going to overwhelm them, but on something that they're going to look forward to challenge. They tend to be assertive. And when I say assertive, I'm not talking about, being overly confrontational. But when I say assertive, sometimes it might mean, what did you just say? Oh, I heard you say this. What did you mean by that? And so it's not necessarily in a way that people would think when we say assertive, but it's in a way that is comfortable for that individual. They set boundaries. They advocate for their own needs. Research says a lot of times when it comes to taking on a new assignment, we know that some folks will say, oh, well, I might not have all the qualifications, but I'm going to try that job anyway. A lot of times women will say, well, I'm going to wait until I can check every box before I take that job. So sometimes we know that for women that are self-confident and are going to push forward, they are going to say, I'm going to try that job anyway, because I know I have the qualifications that are necessary. Maybe not all of them, but I have enough, and I have enough grit and hardiness that I'm going to take on that job. We also know that they, like a lot of us, suffer from imposter syndrome, but they will remind themselves, hey, I've had successes in the past. And those successes, I'm going to remind myself of those successes so that when I go in there for that interview or when I go to that assessment and selection process, I'm going to present myself in a way that I want. So they're optimistic. They default to good intentions of others, but confront others when needed. They have a lot of bounce back when they hit obstacles, and they take care of themselves. They maintain their self-care. They invest in their psychological and physical health. And another thing that we find is a strength among women generally is they can build a community. And building that community in difficult situations is paramount for women getting ahead and being successful in a variety of situations. So I've got a lot of notes. There's a lot we could talk about as far as women's strengths and successful women's strengths, but those are a few. So
I think those are, fantastic strategies, and especially in today's environment, I think a lot of us are going to need to draw from some of those strategies to continue to be resilient and push forward and continue to show our value every single day. And those will help us be successful. Thank you for sharing those.
If I may also add to that, I think this is such a huge component of that human performance model, right? Is that oftentimes, and I'm thinking of the warfighting community, you might be the only woman in your unit. And so how do you find social support? Who's your tribe? Are you feeling isolated or alienated? Do you feel like you're part of the team? Are you being asked to perform? Are you feeling like you have to work harder, right? And so these are all the components of sort of that total force fitness model that I'll get into in my question time. But I think this is a really important piece because looking at the surveys that were presented, I mean, this is a common theme, right? And so what are some of the characteristics that help us to be successful? I think these are great tools, but may not always be a perfect fit in your particular unit. So what do you do? I think sometimes it leads to more questions. That was great.
Rebecca, with the research that's out there on health and brain effects related to blast exposure, those are still in its infancy. So what recommendations do you have for individuals who experience repeated blast exposure or repeated traumatic brain injury? And are there any unique considerations for women and brain health?
Yes, thank you. Thank you very much for the question. I just want to say how excited I am to talk about this with a group of women. Typically, literally 2 months ago, I was at a conference. I was the invited keynote speaker, and I'm in a room with 150 people, and I'm the only woman in this entire room. And this is very frustrating. And women do have very unique considerations with all of this. So I'm going to start with a couple things to lay the foundation for the unique considerations and just considerations in general. Just a couple things about subconcussive TBIs generally, of which chronic blast exposure is a type of subconcussive TBI, okay? The first, this is my framework for understanding this. All of you, everyone in this room is not the typical person. You have very unique stressors that you have experienced in your life, whether you're still in the military now or you're now out. And you can think about it, if you know what operator syndrome is, it's sort of the Venn diagram of your physiological stressors, your psychological stressors, your toxic exposures, your chronic toxic exposures due to your job, as well as neurotrauma, which includes blast. These things have a cumulative effect and an additive effect with each other. They create injuries to your brain and body that look like very common healthcare problems like major depressive disorder. But the injury is different, which is why a lot of people who have been in the military, who have experienced these things chronically, will have to try 6 or 7 different things to try to find something that works, because your injury is not the typical injury. It could be, and some people get relief within the first couple things that they try, but typically they don't. So the idea is your injury is different. Just because your symptoms look like, humans have sort of a set number of symptoms we can possibly show. Just because the symptom looks like something else doesn't mean it is that thing. Also, chronic blast exposure is an inflammatory process, and it's an autoimmune dysfunction. It is immune dysregulation. We see it in the brain when we look on slides. I literally worked in a lab that did this during my postdoctorate. And it is an inflammatory process, okay? Also, very particularly affected, typically blast enters through your eyes. It enters in a lot of other places, but I'm going to talk quickly about the eyes because that's where a lot of blast comes in. Whether you are shooting a pistol, my favorite weapon, the Gustav, or you have some other larger weapon system, it doesn't matter. You could be shooting a .22 and you're still being exposed to chronic blast. Typically, it comes in through your eyes and just wreaks havoc on your pituitary gland, which controls most of the functions in your body, directly or indirectly. It basically controls your endocrine system, along with other systems in your brain. Blast particularly affects the areas such as your emotional and mood regulation, your contextual decision making, the decisions you are making in the moment, and honestly, how the information moves around your brain, if it even gets to where it needs to go. It creates scarring in your brain and all kinds of problems. But this is maybe the biggest take-home message, that there's been a lot of research published recently and more coming out. It affects far more than your brain. Everything it's doing to your brain, it's also doing to your heart, to your lungs, and to your GI system. And all of these systems are connected. So that's sort of the foundation for my recommendations. So first of all, this is the big hard thing. I am pulling from myself and others who specialize in this area. These are the things that we really want. When someone comes into our practice and they have chronic blast exposure, these are the things we would love to have. And the very first that you can do this week, you can initiate, is go get your labs drawn. Go get an endocrine panel. Go get a repeated endocrine panel at different parts in your cycle if you still have one. Do it over the course of the next year, couple weeks, whatever it takes for you. Get a complete blood count, get an endocrine panel at baseline. Hopefully you can go through your primary care to do this. The second, and this is a really big one, if at all possible, go get a psychiatric interview done for how you are right now. You might have been having interviews done and mental health assessments done in the past. I'm not going to have access to those probably. And what I really want to see is you go see a clinician who also knows medicine. So you get a full background, preferably, if at all possible, someone who knows how to do a blast estimate. There are not very many of us. But go get a psychiatric interview. You don't need a diagnosis to do that. Also consider if you have an iPhone, you can do it for free. You can also just go online, just start taking some of those standardized tools, the PHQ-9, which is mood, and the GAD-7, which is anxiety. You can do it once a month. You can do it twice a month, however you want to do it. You don't need to do it often. Establish a baseline for yourself. If you feel that you are already being affected cognitively by your blast exposure, consider finding somebody who knew you before your affected period started and having them just write a couple paragraphs, it doesn't have to be medical, to talk about from their perspective what has changed, how you were before and how you are now. The second thing is inflammation. We women are so prone to inflammation and autoimmune problems. And there are super basic things that we can think about, such as looking at changing 1 or 2 meals a week to a more anti-inflammatory kind of meal. You can also do some supplementation. This is not medical advice. I always have to give that because I am a nurse. But if you do consider supplementation, please talk with a dietitian. Please talk with your primary care. Ensure that the supplements are going to jive with whatever you have going on medically. I also am happy to email you a blast tracker that I developed with a bunch of Green Berets and SEALs that is in production and in use with some SEAL teams right now, which is, I believe, an SF600, which is just sort of a free page in your medical record. And every time you go to the range, you can fill it out and have a medic actually co-sign it, and it can go in your medical record. And it is with all of the baseline stuff that the VA uses to establish what your blast exposure actually is. I also recommend going to something called the Operator Health Index. It is published by the SEAL Future Foundation. The Operator Health Index was developed by myself and some other folks. It's everything that we do for blast injuries. You can literally look at it. They are all evidence-based, and for a lot of you, I mean, they are very culturally congruent with military culture. You'll probably see some things that you like. I also published an article that is free. If you type in Rebecca Ivory Operator Syndrome and Chris Free was the first author on the original Operator Syndrome paper. He and I wrote a nursing article together that is written for anybody who could completely understand it and read it and take something from it. And it is literally how we treat blast if we have somebody come in to see us. And the very last thing, top 5 issues that I see with folks who have been chronically exposed to blast. Pain, hormones, suicide, sleep, and substance use. If you feel that you have some issues in one of those areas, I really want you to consider talking with your primary care about what's going on with that particular area. These are like the top 5 outcomes that I see with chronic blast exposure.
Thank you. Melissa, a question for you. With your background in human performance, so with the unique physiological factors and health needs of females, are there specific training strategies that female service members should consider for optimizing their overall performance? And then how are we seeing these strategies translate into policy programs or initiatives?
So I love this question because I don't think there's a straightforward answer. I think everyone's kind of looking for what's the best way to train or what's the best thing I can do to be the most impactful or the most effective at my unit. And there's really not a perfect answer to that. It's very multidimensional and very multimodal in nature. And so when I read this question, I thought of 2 things specifically. One, we're noticing a significant increase in female service members entering the military, which is great, right, compared to when I joined in 1999. And 2, since 2013, we've seen a significant number of women joining combat arms professions, which is also a big shift, right? And I would say even in the Marine Corps specifically, just in the last couple of years, we're seeing our first infantry Marines coming out as women, right? That's very, very different and change in our culture. And so keeping that in mind, there's still a lot we don't really understand. As you've heard probably time and time again, you'll probably hear some more tomorrow, there's still a lot we don't understand about the female warfighter because of our physiology, because of our physical characteristics, and because of the other things that we're just very different in biomechanically, emotionally, socially, and we have to consider all of those things. And so I think when you're looking at, well, what's the best strategy, you kind of have to think outside the box a little bit. And that's where this human performance optimization term comes in, right? So human performance optimization came from a CJCSI on something called total force fitness. I would encourage you to look it up. Some of you in H2F may have heard of some of this or loosely in other services, but essentially what Total Force Fitness, or TFF is for short, is looking at someone holistically. So looking at physically, mentally, socially, environmentally, spiritually, et cetera, on and on, right? And thinking like, okay, if there's an injury, well, what's contributing to that? Because at the end of the day, if someone's not ready or they don't have good operational readiness, then I don't know that I would feel comfortable as a commander taking them out in combat. Right? Because when the deployment time comes, I need everyone to be ready. And that doesn't just mean physically ready. That means things are good at home, that you're good mentally, you have a good support system, maybe even financially, you're getting sleep, especially if you have a newborn at home, things like that that you have to consider. And so when you're trying to say, well, what strategies can we do? I would say, well, number one, knowledge is power. You have to understand what's going on with yourself, particularly if you're in a special operations situation and you might be the only female in your unit. Number two, you have to advocate for yourself. So when you have that information, you have to be able to go and say, I need this. But that requires some transparency in yourself as well. It's hard sometimes to be able to tell that about yourself, but you do have to have some transparency or have a buddy that can say, hey, look, you're acting a little different. And as a leader, as many of you are in this room, you also have to recognize that in your service members, right? Something's off, something's different, let's have a conversation and find out what's going on so that I can make sure that when the deployment flag goes up, you're ready to go without any concern. And lastly, if we're talking about physical preparation, right, I would even argue this applies to mental fitness and resilience, things of that nature. You have to train functionally. You have to train for what you need to do. In the Marine Corps, we do have MOS-specific standards for training, and I think that's great because that takes gender out of the conversation. But at the end of the day, whether it's physical, mental, social, spiritual preparation, you have to train functionally for what you're about to step into. As far as policy goes, there's really not a lot of policy. I think what we're seeing is conversations are starting, which is great to see that the conversations are even happening right now. The research, man, that was a great presentation earlier to hear USU and say all the great things that they're doing. I would say USERIUM is really leading the way in the Army with their women's performance research that they're doing. We have a long way to go, but I think knowledge is power. If you have that information, take it and run with it and make sure that you're taking care of yourself.
And thank you for talking about policy and where we're at now. I know we talked a little bit about policy earlier, and this is an area I do have some experience with. If we look at this now, not just from the human performance perspective, but if we look at women's health in general and policy in women's health and how this is impacting our military right now, and this touches on the research that we've been talking about as well today. I think we're at this really unique, pivotal moment where we already have the research. We know where the gaps are in a lot of areas. We know that our women are struggling to get access to women's health care in the operational setting. And even in the MTF right now, they're struggling to get access to the women's health care they need. We know where the gaps are. We know that it drives retention. We know access to women's health care is a reason people may continue to serve or not. And it's time to start to fix the problems. And I think we're just beginning to do that. I think there's some efforts out there where people are starting to address that. I know my office works on it, but I also work on it with the other services. I work on it with the Air Force and the Army and the Defense Health Agency, and we're working together to try and fix some of those gaps. And address policy changes. I know with the Navy's Office of Women's Policy, we've partnered to try and address these gaps in policy, get our physical fitness policies correct. In the Navy, we had this wellness PFA that we were making only our postpartum women do that had no official relevance in your record as to whether you truly passed or failed, but really you knew if you passed or failed. And the mental anguish that you felt if you didn't really pass. But we actually didn't really expect you to be in standards yet, which is why it wasn't an official fitness assessment in the first place. And the Navy was going to use it to help identify those who might need extra support getting in standards postpartum. Well, why wouldn't we give all the women the support to get in standards postpartum? So when we're talking human performance, when we're talking about readiness, when we're talking about health and these gaps and putting them into policy, I think we already know the information. We have the data. We know where the gaps are. It's time to get it done and start making improvements. And I think that these events are going to help us kind of to do that and partner with the right people to get that done.
We're kind of a unique breed because, I mean, I'm thinking about the 23 years I was in the Marine Corps, who I was at 20 versus when I got out at 43. There were so many things that happened, right, between pregnancy, postpartum, perimenopause, you name it, it happened, and all out in the field on top of that, right, where you don't have access to anything. So, I mean, we're kind of a unique breed. It's difficult, right? And we have different injuries that we're seeing as a result of that, right? We're seeing, ACL injuries, we're seeing stress fractures, we're seeing relative energy deficiency syndrome, formerly known as female athlete triad, which is huge. And that becomes very important because if we're at higher risk of stress fracture or low body weight, but we're being asked to perform at a percentage that's more than physically would normally demand of an individual, particularly our male counterparts, like what does that look like for readiness? And so we have very specific nutritional needs at all of these different stages of life. We have different training needs. How I trained at 20 is not the same way that I train now at 45. And so we have to keep that in mind when we're looking at how do we really optimize performance. It's not going to be the same. We're not training to a certain data point. We're not just training for the physical fitness tests that we have to take. We have to consider the holistic view.
Yeah, thank you for sharing that. And we, unfortunately, at the last minute, lost one of our panel members who was going to talk a lot about women's health care across the lifespan and menopause and perimenopause, and I know that's a topic that came up today. I'm hoping I fill that gap. She was another midwife. I'm a midwife. I think I can offer some perspective there. But so the question I would have asked her is perimenopause and menopause has been an increasingly popular topic in our society, and as women are serving longer in the military, how are we meeting this need for menopause? And, it may be because I'm in that age group of perimenopause, but my social media is targeting me all day long about menopause and perimenopause. Yeah. Usually it's attached to some supplement they're also trying to sell me. So there is that piece that goes along with it. But so there is work being done to address this. And it's not unique to the military that we are lacking some resources on menopause and perimenopause. This is nationwide. You heard Dr. Hamlin talking about this, and there is a big effort, partnership DOD and VA to come up with clinical practice guidelines for our practitioners for helping address perimenopause and menopause concerns, for women in that age group, because we will all go through it at some point. It is inevitable, but there are certain clinical and health-related factors that go along with that. And how do we optimize women in that life stage? I think traditionally we've been focused on young women who are childbearing age. We've focused a lot on contraception, which is fantastic. We still need that effort. We've focused a lot on pregnancy and postpartum in the past. Still lots of work to do in that. But we've kind of ignored this other age of women who are still going to serve, and we need to optimize their performance as well. So that's my little spiel on where we're going with menopause and perimenopause and taking care of women in that life stage. Carla, another question for you is how can we enhance resilience? I think as women in the military and in today's times, we really are required to be quite resilient. So how can we foster that or enhance that?
I think, first of all, one of the important things is for the individual, the woman, to know herself, to know where her strengths are, to know where her vulnerabilities are, so that she can enhance her strengths and minimize her vulnerabilities. If she is somebody, for example, that is not, okay, I'm talking about myself, not very extroverted, but sometimes being a leader requires you to be extroverted, having a plan. So knowing what your strengths are, my strengths are, I'm a psychologist. I love to get to know people and find out about them. So before an event, and being a military spouse, we go to a lot of them, I need to have my little list of questions in the back of my head so that when I meet somebody, I can say, oh, so what do you do? How did you get here? What are your interests? And that kind of lessens any kind of stress that might be bubbling up because I'm forced into an extroverted situation when I'm naturally an introvert. That's just an example of knowing one's own strengths and one's own vulnerabilities. And how do you do that? Well, you take some time and you could do some professional reading. That's what I said. Angela Duckworth's book, Grit, is a good one. When you know that there's habits that you're really trying to change, Atomic Habits. Has anybody looked at jamesclear.com and read Atomic Habits? And he talks about kind of some step-by-step ways to turn some of your habits that might not be great and to enhance habits that you are trying to develop. And lately, the DoD has developed coaching programs. So a lot of times when folks were looking at self-development or they didn't really feel like they had symptoms that they needed to go see behavioral health, what they really needed was an executive coach. And those programs have been really effective. So there's the My Navy coaching program, there's the USAF coaching, and there's the Army coaching programs. Totally different. It's not mental health. It is an opportunity for you to look at some professional development, enhance some of your skills, taking your leadership to the next level. That will increase your comfort, your skills, and your confidence. There's also Military One Source. They have non-medical counseling and a lot of other resources there. Also, if your unit has an operational psychologist or a performance enhancement wing, there's units and those specialists can also help increase your resistance and help you understand what some of your vulnerabilities are that you want to enhance. And there's things we talked about Grit, we talked about Atomic Habits. I love reading anything by Robert Sutton where he talks about Good Boss, Bad Boss, Radical Candor by Kim Scott. There's a lot of professional reading that you can do. And a lot of times folks know what they need to work on. So just saying, man, I really need to get more sleep. That's helpful. But if you have a plan, more than intentions, but a plan, okay, I'm going to set my alarm, 2100 it's going off, that's my time to get up and go to bed. Because I'm spending too much time on social media. I'm going to mute my social media for 30 days. That's more than just saying, I kind of need to do this because it'll be better for me. But actually having a plan. When people have a plan, they tend to be much more likely to follow through and accomplish those goals. So.
Thank you. How are we doing on time?
About 20 minutes.
Oh, 20 minutes.
20 minutes. I think at this point, we're going to open it up to questions. Every time I've done a panel on women's health.
Oh, I'm sorry, can I just?
Oh, yeah, please. Oh,
Sorry.
go ahead.
Yeah. So I just wanted to sort of stick a pin in something that was said earlier when we were talking about how there's a lot of research. There is basically no research in my area on women. About 18 months ago, a group of women from RSOF approached me and said, can you help us? We're doing incredible research in these other areas, and they need a lot more funding, and we need more data on all of these things. But ultimately, there's very little woman-centered research on things like the effects of blast and all of the other areas that I've talked about. And the reason for that is because typically when researchers go out, this is a male-dominated field. Another experience of mine going to these conferences on blast, and I'm like, one of 5 women in a room of 200 people, and none of us lead research projects. None of us are in decision-making power. And so when we actually are able to collect data, and this is what the women in RSOF told me, that when people come to their units, and I know this from my side as a scientist, and there's women, the women are outliers. We might get some data on them, but we're not using it because they're outliers. And sure, they are, but there's really no information. And I really just want to, when I get information and I want to pass it on to women, I'm extrapolating data, typically. Some people are out there talking about this. I know I have attempted several times in the last 18 months to try to gather a coalition of the willing And unfortunately, with all of the government funding, I'm now looking for private sources just to do research in this area, just start something, get something off the ground. So if you are interested in this area, like, please talk to me. Happy to talk with you and about whatever, but there's really just very little information on women and how they are affected by blast.
And Rebecca, thank you for saying this. When I said we have research on stuff, we have massive gaps in research on women, but we have the evidence to say that we have these gaps in women's health care access, and where our service members get it. And so we don't need more proof of that. We need to fill those gaps and address those gaps in access to health care. The research, we still know there's significant
So
gaps
much
there.
to
And
do,
we need
so
to
much
look at
to
that.
do.
So thank you for saying that. Love to open it up to questions. Every time I've done a women's health panel, there are lots of questions. So excited to hear what your questions are.
And there's an assumption that women aren't exposed to blacks.
There is a huge assumption,
So,
and that's not
women
true.
aren't doing anything.
That's not true.
Hi, over here. Right here. Sorry. Hi, my name is Sierra. I'm active duty. I'm stationed at Nellis Air Force Base as an explosive ordnance disposal technician. And the blast stuff I find very interesting. I'm newer in the career, so I don't have a ton of exposure yet. Some, but little. And I've often thought it's a good idea maybe for me to be tracking and like keeping up with my healthcare.
Yes.
However, there's a little bit of I don't know if I want to say stigma, but a little bit of a holdup, because even people I've worked with have mentioned how, depending on what you tell the doctors in the military, it could possibly place you on some sort of waiver or something that's going to stop you from being able to do the job. So what are your thoughts on that? Do you still go with it and then maybe risk not being able to do the job, or?
Yeah, so that has actually come up. So I worked with a coalition of active duty and recently separated special operators because that issue exists. And how do we track it? And with the stigma and with the concern, and if I report something, am I going to be taken off, whatever, put in a desk job or whatever. So what I have found is that, from my very much an outsider perspective, is that when people get together and talk with their leadership about it, leadership is very open to it. I have found that everyone in a unit is concerned about it, but everyone thinks they're the only one concerned about it. Truly, like this comes up. I would be happy if you emailed me. I can email you the tracking sheet. That has been a conversation point in several Navy Special Operations and Army Special Forces units of, hey, we're thinking, would it be okay if we just started using this? We're just helping somebody out with her research. And so we're doing someone a favor, and would it be okay if we started tracking this? But I think opening the conversation, a lot of people are very concerned, including in the EOD community, very concerned about this, and people just feel like they're the only one concerned about it. So yes, stigma, yes, all of those things. I understand if you're new. If you send me an email, I will get you the briefing sheet.
And I agree with you.
Go ahead.
If leaders required that everyone
Yeah.
quarterly got evaluated, then everybody's doing it. And those records would be available. And if you go off to a special unit to be assessed, you have those records and you're like, hey, this is where I am. Being transparent about it, I feel, is the best thing.
Yeah. And sharing that other units are using it can be very helpful. Yeah.
And blast exposure can have significant impacts on your performance,
Yeah.
right? So difficulty concentrating, making good decisions, sleep, and mental health, high suicide rates in those who've been exposed to blasts. And then when you transition out of the military, what does that look like from a VA disability standpoint? So things that we need to consider, not just right now while serving, but like this is for the rest of your life.
The blast sheet actually feeds into the VA disability questions on purpose.
There are some efforts DoD-wide to look at warfighter brain health and how we're doing cognitive monitoring. But some of that work is just beginning. But I think you'll start to see some stuff over the next year or two. related to that can be pushed out across the DoD.
Hi. So I'm an active duty officer in the Army right now, stationed out of the Chicago area. So really happy to be here. I'm very excited to be here about this stuff. I'm 51 years old. I am definitely going out of business, right? So, my social media feed, of course, is getting hit with all kinds of this stuff, right? I mean, just constant barrage of, all this stuff will fix you, right? You guys are gonna hear way too much about me right now. So I started perimenopause about 3 years ago. I started hormone replacement therapy about a year ago, and it has changed my life. It has changed my career, all right? I was gonna get out, I was done. I was like, I'm done, I hit my 20 in a day and I'm finished, and I'm done, right? I have more stamina, I sleep, no hot flashes, no mood swings. I was about to kill one of my people one time. I got so angry, the rage was crazy. None of that stuff is happening anymore. And it changed my career. It retained me in the Army at the maximum capacity that I'm at right now as an Army officer. And I'm going to stay to keep perpetuating the knowledge that I have and keep going. But that's because of the hormone replacement therapy. There is nobody that's advocating for this stuff. For people who are in this part of their career that have the most knowledge, and they're getting out. Women are just getting out because they're like, I can't really do the PT test anymore. I don't have the patience for people. Changed my life. I had another lieutenant colonel come at me the other day, and she said to me, she goes, I don't know what's going on. I don't want to be social anymore. I don't want to get out and do anything. I think I'm depressed and all this kind of stuff. I was like, you need to go get your hormones checked. You need to talk to your doctor. This stuff, it changes everything. And nobody says anything about it. You have to advocate for yourself. I would love to go to my doctor and say, can I please get an endo panel done? They looked at me, they're like, a what? You want a what? Like an endocrinologist? Well, you have to do that at a certain time during the month. And your cycle is almost over, so it's okay, we won't do that now. And they throw you birth control as a way to manage your hormones. I don't need birth control, I need replacement therapy. And so you have to advocate for yourself, and that's what's frustrating, and that's what I wanted, like, how do we get consistent medical care across the board? There's no consistency in any of it. I would love to be able to go to one of these hospitals and say, hey, I'd like to do this, and have them actually look at me and say, hey, we can do that for you. But instead, they're always out of stock on estrogen patches. They're always out of stock. And I have to wait for that to get in, and I have to make sure I order it in time and all that kind of stuff. So consistency across the board. When do we get to that? Do we get to that? Like I said, I'm in Chicago. My Great Lakes Naval Training Center, that's my closest place that I can go to. I go to the VA hospital there. I don't have like an Army MTF that I can go to. So hopefully someday we get to that consistent knowledge across the board of what it means to take care of the holistic woman.
I mean, I don't have the perfect, I don't know if any of us have the perfect answer to that.
Right.
But I would say that when it comes to decision making in the military, it's a slow churn. It's kind of akin to turning a large ship, right? It's very, very slow. But what drives decisions at that GO level is data. And that's what they want. And where we get data is research. And so we need, and this is all we've been talking about, right? There's significant gaps in the research. So unless you have like a glaringly obvious issue, they're not going to prescribe you certain things. It has to be, and we see that even on the civilian side when you get out, like for perimenopausal and menopausal women who are saying, unless I have an issue, my physician's saying, we don't want to go HRT yet, right? And so I think as the research starts to boost and policy follows, and so does data, I think you'll start to hopefully see more of that now. Unfortunately, you'll probably be retired by then. Right. Also, I'm also in Chicago, so I feel you on the weather up there.
So
but yeah.
I will add, there are some big efforts that are happening right now to address exactly what your concern is. So you heard Dr. Hamlin talk about there is now a menopause clinic at Walter Reed, and I believe that it's virtual, so you could
And they are seeing patients cost basis, not just a Walter Reed.
Oh,
I'm gonna get with you after this.
thank you. Yep. Right. And we
Name, phone number, social security. Yeah.
but also what we do know is even our clinicians are not well trained in menopause, and that includes your OBGYN physicians because the American College of Obstetricians and Gynecologists has recognized the training gaps in menopause. So at the Uniformed Services University, they are currently working on revising curriculum so that all the clinicians are prepared to recognize and treat menopause more appropriately. I've talked about the VA and DoD clinical practice guidelines for addressing menopause. I have some handouts with me today on hormone replacement therapy and current best practice. But also, the practice guidelines have shifted over time. We were recommending it, we weren't recommending it, we're back to recommending it. So again, sometimes we have to look at individual risks when talking about who to prescribe for. So if you're not finding a provider who knows how to talk about perimenopause, menopause, hormone replacement therapy, then ask for another provider. Ask to be, for a referral to specialty care. Ask to see somebody who knows menopause and keep advocating.
For yourself.
You do.
You have to, and that's across the board for anything you want. Like, you have to tell your doctors what you want. That means you have to do your own research, and you know how that can be, especially when social media is like, you're broken. Go here and fix yourself, kind of thing. So yeah.
Yeah. So what I can tell that I've done out of the Office of Women's Health, and again, I don't work for the Army and Air Force, but Army and Air Force and Space Force, Coast Guard, you're welcome to find our resources on our Navy Women's Health webpage. I have some pocket cards that'll direct you to their webpage as well. But while we're waiting for some of these clinical practice guidelines to come out, or some of these bigger efforts to come out, Navy Medicine, we've started a toolkit for perimenopause, and we're not talking just hormone replacement therapy. We're talking about the mental health impacts of perimenopause and menopause. We're talking about the musculoskeletal impacts of perimenopause and menopause, bone health, all the considerations. I have some of the handouts that go in that toolkit with me today, and I have some pocket cards that'll take you to the website with some of these women's health resources that I'm happy to share if you find me afterwards.
One of the excellent things you did is you saw someone else, and you built that community. And she was probably sitting in a meeting going, "Oh, is it hot or is it just me?"
Right. Yes.
When you can tell somebody, "Hey, I found a way out," that means a lot. That really means a lot. Right.
Ladies do not have to suffer. Right? Like there is a way to fix that. Yes.
Right.
We have about 5 minutes, so maybe 2 more questions.
So it's not so much hi. I'm Aisha Dinkins. I'm an NCO at Fort Campbell. I'm a patient administration NCO. So my comment is not so much a question. Healthcare, right? So hearing what you guys were saying, if you're worried about healthcare, if you're worried about telling your provider, if you're worried about not hearing your provider not hearing you, right? We have this lovely thing called patient advocacy. You can not report them, but report yourself to them. Let them know, hey, I'm not being heard here, so where can you refer me? We have TRICARE Prime, which most of the active duty soldiers are Prime, right? You do have the option to become select if you're not getting what you need. So if you can't get it in your area, they'll send you to a civilian provider. Civilian providers are more likely to listen because, 1, they're getting paid to listen. 2, they're going to do what's best for you. Unfortunately, especially in the Army, they don't hear us. Male or female, I've run into. Please, young lady over there, do not be scared to report things that will distract you from your job. You know what I mean? Because like she said earlier, VA counts. It's a lifetime. We're here for 20 years, maybe a little bit more, but you got to think about your life and how it benefits you yourself. So for those of you who do have issues that are like, okay, you know what, this is starting to affect my job, let me say something. Because later down the road, that's going to help you for your benefits, and it's going to help you to get proper care. So don't be scared to report it and say what you're going through. I know they always say, push through. I'm old Army, so I got that a lot. But no, I tell them now. But that's it.
Hello.
Sergeant Panetta. I am from New Hampshire Army National Guard. I'm active duty for the Guard. And I know this has been quite focused on the active component. So my question is, how can we integrate the National Guard and the reservist into this? Because I think oftentimes we are lost in this process, especially when we talk about the medical field, when you have that. I know we're not excited about the MTFs and how we are heard there, but when we have to receive treatment from the civilian side and medical side for us, they have no idea what we need. They don't know how important it is for us to be seen and need to be able to be physically fit. They're like, oh, you're fine. So I guess that's my big question, and how we're going to be heard, have the surveys completed. I know there was a very small percentage of surveys pushed out to the National Guard and Reserves, so that's my question. I guess a rhetorical question.
I'll take a stab at that one, because I finished my career in the reserves. So I understand the unique challenges of the reserve or National Guard component, including the active duty support staff that's there. So if I speak specifically to the reservists, the challenges that exist are the other 28 days they're not with you, right? So how are we getting after some of these things that we need to get after when we're not seeing them for 28 days? Some could argue, well, it's engaged leadership. How are we reaching out to our service members during that 28 days to make sure they're getting the care they need, they're doing their follow-ups, or they're PTing, or they're eating right, they're sleeping, without micromanaging them or feeling like we're overreaching into their personal lives. I think the challenge is also that when we bring service members into the unit, we have eyes on them all the time. We have a lot more control over what they're doing. When they go back to their respective homes, I have no idea what that home life is like. Socioeconomically, if there's job access, if there's healthcare access at all. And so this is the challenge that we live. And so, I don't know that there's a perfect answer to that, except to be as engaged of a leader as you can to help them find resources. And even as reservists, there are resources like Military One Source, et cetera. Now, if you're active duty and you're in the middle of perhaps small town America, I would offer that building relationships with your providers. So relationship building is everything. In the reserves, we say it's all about the relationships, because you have to build relationships with your community in order to get what you need. And if they don't understand, it's not because they don't care, it's just because they don't know.
I would say this is the importance that we've been talking about today of having diversity of representation at the table. So when we're making healthcare decisions, policy, decisions, when we're looking about who has access to what healthcare, as we're trying to de-silo efforts, we have to look at who's at the table and who's missing from the table. And maybe that's somebody who's missing, and we need to ask who's not here that we need representation from. So I would say that's probably something we need to work harder at as considering our National Guard.
Unfortunately, that's time. Sorry.
Nope. Well, thank you for letting us speak with you all today. Thank you for inviting me to be on this panel. Please see me afterwards if anybody's interested in any of the handouts I mentioned. And thank you for all of our wonderful panelists and all their information today.
All right, now we would transition to our breakout sessions. We have two breakout sessions. First topic is interpersonal, physical, and psychological safety concerns and assistance for military women. And the second will be physiology and performance through women's life cycle. This time you'll have the opportunity for more in-depth discussions and engagement, and the breakout sessions will take place right here in this theater, and we encourage you all to participate and actively and make the most of these conversations. Before we start, please take 5 minutes, and the breakout sessions again will be here in this theater.